Hello everyone, welcome to YouTube live session on consent questions. We are going to do SBAs and EMQs for the very important topic and very confusing as well. So this is specifically for the part 2 students. We are going to talk about the EMQs definitely, and that is the most important part of this session. So welcome you all to this session again and very warm welcome on this afternoon. So let's start the session. Who all has joined? Yes, I can see many of our students have joined the session. Yes, good. Okay, so let's wait for a moment till everybody is joining and the link being shared so that we can have maximum people around. Yes. Welcome. So, yes, good to have you all here. Mm-hmm. Mm-hmm. Okay, so let's start. So this is today we are going to talk about the consent. So why consent shows up everywhere? It is woven through almost every part 2 module, not just ethics and law. The most important thing is it's a very important part of patient safety. So if you are doing anything like wrong and the patient is not consented for it, anything you are doing like that, then it's a problem of the patient safety. So it is very important to know about that. High yield theme, consent records in SBAs and EMQs across the IT governance, surgical complication and emergency care. This is a highly asked topic. Like we talk about the generic competencies. Many of the students actually lack in that. So what it is? Consent is one part of it. It is an examiner's favorite topic. Capacity, best interest, consent for teaching anesthetized patients are repeatedly being asked. So today I'm going to concentrate more about the consent in the cases where you find some unexpected findings in the surgery. So this predominantly I'm going to focus on today. Sometime other I'll take the other important topic, which is the consent in the mental capacity patients. That is also a very important topic. So we will talk about that as well someday. So, but today I'm really concentrating on the consent related to the surgical parts. Yes. Okay, so good evening, everyone. Yes, Dr. Beena, Dr. Meenakshi, Dr. Yashli, Dr. Richa. So good to have you here. So, Dr. Srinivasan Geeta. So very good. So let's start. So if you know this properly, then the marks are very easy. So easy marks if drilled properly. Now, what are the consent rules which you need to follow? So let's talk about some basic rules in this, and then we will start talking about the questions. Where you will apply those rules in the question. This is the same way we teach in our classes as well. When we talk about certain rules, which I call as formulas, like we keep this whole concept as a mathematics. You have the formulas, and then you can solve plenty of questions by applying those formulas. So same thing comes here. We are going to talk about certain rules, and then we are going to put up these rules in the questions. So very quick 10 questions I'll be taking after these rules. And the last ones are very important. So stay till the end and keep solving the questions in an interesting way. So consent rules that win marks, valid consent. This is very important. So what do you mean by a valid consent? There are three pillars to this. One, it should be voluntary. It should be fully informed. And third thing is patient should have complete capacity to give the consent. So voluntary, informed consent and with capacity. It can be verbal, written or non-verbal. This is also important. So you should know when it is verbal, when it is written and when it is like implied consent. Life-threatening versus not life-threatening. So always remember, non-life-threatening procedure, you will not consent. Whenever you are thinking that I should do this or not, the only question you have to ask yourself is, doing this is this life-threatening or not? So non-life-threatening procedure without consent, do not proceed. Reschedule and consent later. Always remember this, irrespective of, even if the patient is going to have a second surgery because of it, then also it is fine. Don't do it. No proxy for adults. No one can consent for the adults on behalf of another competent adult. Any partner's relative, husband, whatever relationship it is, they cannot unless and until they have any power of attorney, right? So no one can give consent on the behalf. Capacity. What is the capacity? It's a three-step process. He should take the information, person can effectively take the information, then think over it, weigh the information, and then communicate you back. So understand and retain. He's gaining, he's retaining, and then he's thinking about it, he's weighing the information, and he's going to communicate you back. So this is complete circle is the capacity. Best interest, if an adult lacks capacity, acts in the best interest. But always remember, person should not be having capacity. But otherwise, if he is fine and he is consenting for something which is not good for her health, and you see that she may die because of this, but still you cannot intervene, right? Because the person has decided to take that for him in a full capacity. So this act in best interest only come into action when the adults lack capacity. Teaching and exams, explicit consent is required for pelvic examination on the anesthetized patients. So this is very important, because in exams they do ask about the anesthetized patients, which is a very important topic here to talk about. So now let's solve some questions based on it, and everybody is going to answer, and as always, I'm going to pick up the fastest finger first. So let's start. A consultant asks, what type of consent is required for medical students to perform pelvic examinations on anesthetized women? Consultant asks, what type of consent is required for medical students to perform pelvic examination on anesthetized women? This is a training scenario. Trainees are there and the pelvic examination needs to be done. So how this can be done in these patients? So yes. Okay, so consent from the consultant responsible for the patient. Formal consent is not required as this is a part of clinical care. Verbal consent from the woman, verbal consent witnessed by the member of the theatre staff, or the written consent. So yes, I can see two answers. Any more people? Like there are so many people. Why not everybody? Try answering. There is no way, no issue. If it goes wrong, it's fine. You can try answering. That's not at all an issue. Yes, I want more answers in the chat box. Yes. Let everyone just take that opportunity. See, you can be wrong here, but if you be wrong here, you will remember the correct thing in the exam. Always remember this. So yes, Dr. Deepthi and Dr. Romil both have answered it correct. This is written consent. So this is written consent and this is the correct answer here. Now, what is the rule here? Explicit consent is required for the presence of students in OBS and gynae consultations in theatre and for clinical pelvic examination. For if it is like you are sitting and you are looking at the patient and the trainee is standing, so that's okay. But if you are going to do anything on the anesthetized woman, that consent must be written. Verbal or implied is not enough. Consultant cannot consent on her behalf. Part of the clinical care does not waive it. So it is very important that you have the written consent in the anesthetized patients, even if it is a simple thing like pelvic examination. So very well answered. Two of you answered very right. So let's move on to the next question. So here we move on to the next question. You assist a general surgeon with a 23-year-old woman having appendicectomy for suspected appendicitis. This is a very favorite scenario of RCOG and it appears in the exams many times. So just look at this very seriously, right? This can come in multiple variations. So you assist a general surgeon with 23-year-old woman having appendicectomy for suspected appendicitis. The appendix is normal, but there is 5 into 6 centimeter ovarian cyst. There is no torsion. Only 5 into 6 centimeter ovarian cyst is there, which is thought to be the cause of her pain. She consented for appendicectomy and proceed. What is the appropriate management for this patient? What is the appropriate management for this patient? Okay. So yes. Okay. So B. Perfect. So many correct answers. Very good. And the first correct answer is from Dr. Swati Jain, then Dr. Richa, then Dr. Deepti, Dr. Romil, and once again, Dr. Meenakshi, Dr. Kanksha, Dr. Yasha, Dr. Srinivasan, Geeta, Dr. Beena. Yes, Dr. Lubna says abandon the procedure and consent again. So that's okay. So basically, the same thing is there. You leave the cyst here. Okay. Leave the cyst and arrange gynecology clinic follow-up. So that B is the correct answer here. So what is the rule we are applying here? As we said, whenever we have to think about like whether to operate or not operate. So one question you have to ask to yourself, is it a life-threatening procedure? No. Simple ovarian cyst, it's not life-threatening. So leave and arrange gynae follow-up. A woman must be made aware of any proposed procedure and its consequences before surgery. Non-life-threatening procedure not consented for should not proceed even if a second operation is needed. The cystectomy was never discussed. The cyst is benign looking with no torsion, not an emergency. So oophorectomy might be needed if the bleeding were uncontrolled. Another reason not to proceed unconsented. So in this case, there is no emergency. Everything is stable. So we can just wait and watch. So very good. A huge round of applause for all of you. You are the on-call registrar asked to assist with a 23-year-old woman. At diagnostic laparoscopy, the appendix is normal, but there is 5 into 6 centimeter ovarian cyst on the right. No torsion. The surgeon thinks this is the cause of pain and asks you to remove it. She is consented for appendicectomy and proceed. What is the best management? She is consented for appendicectomy and proceed. What is the best management here? Yes. So what we are going to do in this case, okay. So this is, I think, the same question. So we can just skip that question and move forward. A pregnant woman attends the accident and emergency with abdominal pain and vaginal bleeding. 7 weeks since her last period. She becomes tachycardic and hypotensive and collapses. Plans are made to take her to theater. As per case of NCEPOD, which category of intervention is this? Slightly away from the consent, but it is still a part of the clinical governance and the generic competencies. So what is the category of intervention here? It is 1, 2, 3, 4, 5. So which category does it belongs to? 1, 2, 3, 4 and unscheduled. So basically, yes. So 1, 1, 1, yes, that is the correct answer. So 1, it is immediate. So as you see here in the box here, ruptured ectopic with collapse. This is an immediate threat to life. Theater within minutes. So 1 is within minutes, hemorrhage or the ruptured ectopic. 2 is within hours. So that is going to be the fracture like. 3 is within days. tendon injury, and 4 is the planned, like varicose veins, which we can take later as well. So 1 is the correct here, and who all has answered right, right. There are many rights here. So the earliest one is Dr. Swati Jain, Dr. Meenakshi Mishra, Dr. Kansha Chaurasia. They are the first 3 ranks for answering this question. Absolutely correct. So here I'm going to take the next question. Let's look at this. At emergency cesarean for failure to progress with chorioamnionitis, the uterus is atonic. After uterotonics, a B-length suture bleeding continues. Blood loss is 4000 ml and the anesthetist warns of impending cardiac arrest. The consultant wants to perform a hysterectomy. The patient was not consented for hysterectomy. Another consultant is 2 hours away. What is your next step? So at emergency cesarean for failure for progress of chorioamnionitis, there is a huge PPH going on here. And the anesthetist is saying that it is going to be cardiac arrest. So you want to do the hysterectomy, consultant wants to do the hysterectomy, but usually we say that for hysterectomy, we need 2 people, right? We need a second opinion from the consultant. So are we going to wait for the second opinion from another consultant? He is 2 hours away. Or we are going to perform a hysterectomy. Or it is hysterectomy with bilateral salpingophractomy, because I can see D option also in the chat box. So C, D, E. So let's look at this. Definitely you all recognize that this is a life-threatening, right? This is a life-threatening concern. So we need to go forward with some kind of a surgery for it, right? Or some kind of a procedure where we can just save the life of the patient. So this is how we are going to, we know that only hysterectomy can now prevent her. Now, but the other consultant is 2 hours away. And usually what we do is we need 2 consultants, okay? But because he's 2 hours away, so we need to take decision in the best interest. So you can go ahead with the hysterectomy. Secondly, you will go ahead only with the hysterectomy. Why will you go ahead with the bilateral salpingophractomy? It is not required because the bleeding is from the uterus. So you need to remove the uterus. So it is only the hysterectomy which is the correct answer. So C is the correct answer here. This is a life-threatening emergency. The consultant must act in the patient's best interest. An experienced colleague's opinion should ideally be sought, but waiting 2 hours risks death. So action cannot be delayed. Ideally, she would have been consented for hysterectomy document fully that it was done as a life-saving measure. BSO is not indicated because in best interest, we will do only the bare minimum. The minimum which is necessary to save the life of the patient. Now coming to the capacity and the best interest principle. Hospital staff have a right to work without fear of abuse or harassment. Conflict and aggression from patients and relatives is complex and multifactorial. Clinicians must recognize warning signs. A patient lacking capacity needs an urgent decision made on their behalf. Which principle should guide the decision? So if you have to take the decision for a patient who is lacking capacity and it's an urgent decision, then what you will do? You will go for the decision, or you will wait, or you will first get the capacity looked upon. No. Okay, so the options here I can see is B and E. But the B is like advanced directive. It's not mentioned that there was any advanced directive, right? So the only thing what they are telling you is the patient capacity is not there. Now you have to take a decision in the urgent scenarios. So the simple thing which is there is the best interest principle. It is only about the best interest because there is no need of like advanced directive. If available is a very good thing, right? And then we can go according to that thing. But now this is a urgent condition. So there is no mention of the advanced directive in this case. So better answer is that you take the decision in the best interest principle. So that is the correct answer here. E is the correct answer here. And let me see who answered the E first. Dr. Deepti and Dr. Suvida. So they have answered it first. Dr. Kaveri, Dr. Lubna, Dr. Nudra. Yes, Dr. Kanksha, Dr. Swati, and Dr. Aisha. So these all have answered it correctly as the E. Best interest principles for an adult lacking capacity. Decisions are made in their best interest under the Mental Capacity Act. A valid, applicable advance decision would take precedence, but only if one specifically applies. No relative or next of kin can consent for a competent or incapacitated adult in England and Wales. Best interest weighs the patient's known wishes, values, and clinical factors, and not other preferences. Yes, Dr. Beena Tandon also answered it, right? And Dr. Jia Shah also. So here it is the E option, which is correct. Okay. So let's move on to now the EMQs. So these were the SBAs, still the easier part. And now we are coming on to EMQs. Now the format that catches people out, the EMQ. One long option list, several stems. Each option can be used one or more, and the skill is matching the best option to each scenario, fast and under pressure. This is the long list of the options, right? Abundant surgery, discuss with the patient, ask the patient to sign a new consent form, ask the hospital solicitor, abundant surgery. So let me first read the question and then I will take you back to the EMQ list. So here is the question. 32-year-old woman with 5 years of infertility is booked for a laparoscopic dye test plus minus treatment of endometriosis on a registrar list. While doing the laparoscopy, you are alarmed to see a 4 centimeter hematoma in the right infundibulopelvic ligament, which is expanding and starts bleeding while you manipulate the uterus. So basically, let's just revise this scenario because then I will take you to the options. So the patient is booked for laparoscopy dye test with treatment of endometriosis. Now, while you are doing this, there is a 4 centimeter hematoma in the infundibulopelvic ligament, which is actually started bleeding and it is expanding. So what you can do? Now, these are your options. You can choose the one and I'm looking for the answers here. Okay, call consultant for second opinion is one option. Then what? Then what? Yes. Any more options? Yeah. Yes. So looking for this is an important question. This has appeared in exam also sometimes before as well. So very, very important to see. So there are two answers, F and E. Okay, what else? F, okay. J is what? Let me look at perform a laparoscopy. Okay. N is N is the perform laparoscopic oophorectomy, call the consultant. Look, okay. So basically, if you look at this case, so definitely we are not going to call not call a partner or anybody to take the consent, right? Because there is nobody who can take the consent on behalf of the patient. So anyway, abandon the surgery and contact the partner is not a correct answer. Now the confusion is between F, J, M. Okay, there are multiple confusions here. So now in this case, either you operate or you call the consultant for the second opinion. Now the best answer would have been call the consultant and start operating because the patient is having expanding hematoma, right? So you need to quickly do the hemostasis at that point of time. So if it is only about calling the consultant and waiting, then it's not possible, right? Hematoma is increasing. So you need to act fast. So perform a laparotomy and do an internal iliac artery ligation. This is the correct answer because in this case, you are not removing anything. You are not doing any hysterectomy. You are just trying to achieve the hemostasis by the ligation. And meanwhile, consultant can come in and join. So as expanding bleeding hematoma of the infundibulopelvic ligament is a life-threatening emergency, Surgeon must act in the patient's best interest. Definitive control of hemorrhage takes the priority. So life-saving surgical action cannot wait for fresh consent. Document the indication already clearly afterwards. Abandoning or merely observing would risk exsanguination and not an option here. Because it's a growing hematoma, so it needs action. So first one to be the right answer, Dr. Swati Jain and Dr. Malika Burman. And then we had Dr. Nudra, Dr. Richa, and Dr. Beena Tandon and Dr. Romel, so Dr. Dimpy, so Dr. Kanksha, Dr. Yasha. So if someone is not expert in the internal iliac ligation, then you will have to wait for the consultant and then go further, or any person who is trained, who can do that. That is there. Okay. So 40-year-old woman gives consent for laparoscopic sterilization. You finish the procedure and notice a 3 centimeter cyst on the left side. Her scan report from 8 months ago showed an incidental finding of dermoid cyst. So you notice that there is a 3 centimeter dermoid cyst here. When you are doing the laparoscopic sterilization, you notice that there is a 3 centimeter dermoid cyst. Now this is the options in front of you. So what is the correct answer here? What is the correct answer here? Okay, so do nothing, do nothing, do nothing. Okay. So would you like to go ahead with the sterilization or not? You will go ahead with the sterilization, but you will not do anything for the dermoid. So do nothing is the correct answer. Very good. So dermoid was an incidental asymptomatic finding and was not consented for at the sterilization. Asymptomatic dermoid cyst can be managed conservatively with the follow-up scans. There is no emergency, so removing it would exceed the consent. So just document the finding and arrange outpatient follow-up or the discussion. So K is the correct answer here. Okay, coming to next. A 19-year-old woman presents with a pain in right iliac fossa. The on-call surgical team performs a diagnostic laparoscopy for suspected appendicitis. On examination, the appendix looks normal with the new omental additions. So appendix looks normal with the few omental additions. Now what? Now what it needs to do? Yes. Do you want me to go back to the options? Here it is. So, yes, what is actually happening here? So, okay, abandon surgery and discuss with the patient. K is the do nothing is, okay, A and yes, A and K. I can see two options here. A and K options are on your screen. Yes, A. Abundant surgery and discuss with the patient. Okay. So because the appendix is normal here, right? Because the appendix is normal here, so we do not need to do anything in this case, right? Now, A also means the same thing. Abandon the surgery and discuss with the patient also means the same thing. But K implicitly just says that do nothing. That's it. So it's a better option here. This is how you will have options in your exam also, right? Be direct, like what is the direct answer? So a normal looking appendix with only a few mental additions in a stable patient does not warrant an unconsented additional procedure. There is no consent for and no emergency indication for removing anything further. Document the findings and manage conservatively. Discuss with the patient afterwards. Proceeding to remove the appendix or the additions would exceed the diagnostic consent. So currently what you need to do? Currently it is about do nothing, right? So Dr. Richa, Dr. Suvidha and Dr. Nudra, they have answered it correctly. Okay. Now in this case, unexpected ovarian mass during sterilization. A 34-year-old woman undergoes the laparoscopic sterilization. She consented for bilateral tubal ligation only. On inspection, a 6 centimeter right ovarian mass with irregular surface and papillary projections is found. She is otherwise well and not aware of this mass. Non-prior discussions about oophorectomy or cancer risk were held. Now they have given you the same kind of ovarian mass, but here they have given you irregular surface and papillary projections, which means that this could be malignant as well. Okay, so this is kind of, it could be malignant as well. So now in this case, what to do? Now in this case, what to do in this? Yes, although it is malignant, C and B, proceed only with what was consented. Do not proceed, retain the unexpected finding and close it. So you can do the sterilization, that is fine. You can do the sterilization, that is absolutely fine. So Dr. Malika and Dr. Kanksha, they have answered it right. Dr. Romel, Dr. Dimpy, that C, proceed only with what is consented. We do not need to postpone the sterilization, okay? Only the sterilization was consented, so that we can do, but do not take any biopsy of that particular mass, right? Okay, so there is a question for the previous question. Now, always we have to discuss with the patient so that she will also know. That's okay. That's okay. We can do it later. But currently there is do nothing. You do not have to do anything right now. Okay. Now, intraoperative discovery of unexpected findings during surgery. Now, what is it? Is 29-year-old woman undergoing diagnostic laparoscopy and dye for infertility has a grossly dilated hydrosalpinx on the left. No prior consent for salpingectomy was obtained. You believe it affects fertility outcomes. So no prior consent for salpingectomy was obtained, but you see that the patient has a grossly dilated hydrosalpinx on the left. And you think that it can affect the fertility. Can I take the biopsy? No, you cannot take the biopsy. Okay, so what is the answer to this question? It is hydrosalpinx. Can we remove or can we not remove? So yes, again it is do not proceed. Retain the unexpected finding and close. Salpingectomy impacts fertility and future options. Without informed consent, you should not proceed. Discuss the findings and reconsent later. Now in this case, why it is not C and why it is B? Because see, ultimately you are going to do the diagnostic laparoscopy and dye test. Okay, if you say proceed only with what was consented, that is, you are going to do the dye test in the hydrosalpinx tube. No, you are not going to do dye test in the hydrosalpinx tube. Now, so you do not proceed with the dye test. You are not going to proceed with the dye test. You are just do not proceed and retain the unexpected findings and close. What about G? Document and arrange staged procedure later. Documentation is important, but this is something which is going to come later. Right now, during the surgery, what you do? Only by documenting is not a part of surgery. You are in the middle of the surgery and you have to take the decision whether to operate or not to operate. So the question is about that. If we leave that and we move on to like, I will document later, so that's okay. It's not there. Okay. So in this particular question, C option is also not correct because dye test you are not going to do if there is hydrosalpinx. So do not proceed and retain the unexpected findings and close. Okay, so here is another question. 25-year-old is undergoing laparoscopy for ovarian cystectomy. On entering the abdomen, a ruptured inflamed appendix is found. The patient is febrile and the surgical team includes a competent general surgeon. So can we proceed here? Surgeon is there. He can operate. There is a ruptured inflamed appendix is there. So shall we operate or shall we not operate? What needs to be done here? Yes, 25-year-old patient and yes, now in this case, we can go ahead because this is a ruptured appendix, right? Ruptured appendix. So, life-threatening condition. So, remove the unexpected finding without further consent. This is very, very important because here we have to act in the best interest. So, we need to remove this patient's appendix. So, operate is the correct answer here. Nobody has answered it as operate. Okay, seek emergency consent under the best interest. No, we are not taking any consent from anyone. So H is not correct. It says that you take the emergency consent. From whom you will take the consent, right? You simply go forward and operate the patient. So remove the unexpected finding without further consent is the best answer here. So A is the correct answer here. Okay. So here, no need to laparotomy here. Depends on how the surgeon can go ahead. He can go ahead with a laparoscopy or laparotomy. That's a different point of view. But the most important thing is remove the unexpected finding. That is the decision of the surgeon to go by how to remove it. Proceed as clinically indicated despite lack of consent. There is no lack of consent here, okay? We have not suspected that, so there was no consent, okay? So simply without consent, we are proceeding without consent. It is not that we have taken a half consent. So the word lack of, this is a play of words, okay? So no, F and A are not same. And in your EMQ questions, you will have these kinds of options which will look same, but they are not actually same. So remove without further consent. That is the most appropriate thing you are going to do. So A is the correct answer. F is not correct because it's not that you have forgotten to take the consent, right? It is not lack of consent. You took the consent what was relevant. So the pattern behind every consent answer, is it life-threatening now? If yes, act in the best interest. If no, you cannot proceed. Was this procedure consented? Incidental findings that were not discussed are almost never removed on the spot. Adults can't be proxied. You cannot take consent from the kin or the partner. Default, abandon and reschedule for non-emergencies. Wake, inform, consent and do it properly later. So that was, we did so many SBAs and EMQs, and you see that EMQs are won by repetition and pattern recognition because as you see that the options are very close to each other. So you need to have a good and a quick thought process over it so that you can immediately know what is the correct answer. So you don't get fast by reading explanations, you get fast by doing hundreds of stems. So repeated practice is what is needed until the option list becomes second nature. This is exactly what the workshop is built to do. So this is how we are going to conduct in our upcoming EMQ workshop. If you are still not in our batch, like already those enrolled students, they have access to the EMQ workshop. But if you are still missing on to preparation with MRCOG courses, then this is your last turn to be in MRCOG courses for the July exam. So EMQ workshop, 10 hours of pure EMQ practice, guided timed exam style, 3 days, 4th, 8th and 9th June, 8:30 p.m. onwards. It gives you enough time to go through EMQs of all this, and then you will have next 20 days to revise them as well. You will have all the recordings till your July exam and mapped exactly on what is asked in the exam with a clear explanation and particularly choosing the one best answer which the examiner is looking for. So if you are looking for the enrollment, this is what you are getting. And currently for the early birds, we are also giving you a 200 question mock test, paper 100 questions and paper 2 with SBAs and EMQs in both. And you will have a live mock discussion there as well, so that you can discuss all your queries and get the correct answers here. Every answer and every distractor explained, and RCOG exam patterns, sit like a complete paper before you go to exam. Assess yourself, know. And this will be almost like 10-12 days before the exam, so that you have still 10-12 days to go further with the mock improvement as well. First, do the EMQ workshop. Just do that thoroughly and then appear in the mock and then see your performance. It is definitely going to make a difference in your marks. Those who are for July 2027 and want to prepare in 70% less study time with access till pass, with everything included in the full course also has included crash course, EMQ workshop, a good SBA EMQ techniques, and a mathematics-like solution of MRCG Part 2, where you have formulas and the applications with all the mocks and a good community support, then you are welcome to start now, because this is the right time to start for the January if you don't want to feel overwhelmed. If you just want to go by slow study, this is the right time to start for the January 27. So anybody who wants to sit for the January 27, strong on theory but slow on EMQs, any international candidates, any re-sitters, first timers are really have a very good opportunity, because you will be directly learning those summed up things. Okay. And for those who have already appeared in the exam, they're missing on that clarity. That clarity is what we promise in our course for you. So save your seat, EMQ workshop or Part 2 course, depending on what you are going to do. So here is the website, here is the phone number, and here is where you can just mail and get back to us. You can take the screenshot, that is there as well. Now, any questions from your side are welcome. And I can see already there's a lot of feedbacks. Great. Great session. Thank you. Are we enrolled in this? Yes, you are already enrolled in that. I'm already in the community. Should I join this again? No, if you are already a full course student or a crash course student, you already have the access to the EMQ workshop. It is only for those who have to enroll new. They will have to enroll separately. Thank you so much. Keenly looking forward to EMQ workshop to fasten the learning. Yes, that's really going to be a very intense. We are going to talk about the repeatedly asked EMQs, so that will give you a very, very good practice. Yes, thank you everyone for joining. Thank you. Okay, bye-bye. Take care and have a nice evening ahead. And we'll meet again next Saturday with a new YouTube live session. See you all there. Bye-bye.